If someone you love, a parent, a spouse, a grandparent, has been diagnosed with dementia and is taking any medication to manage their behavior, I need you to stop what you're doing and listen to me very carefully right now. A massive study involving over 165,000 patients was just published, and what it found about one of the most commonly prescribed dementia drugs should alarm every single family in this country. There is a specific drug being given to millions of seniors with dementia at this very moment, and this study just proved that it is triggering strokes in far more patients than anyone previously believed. By the end of this video, you will know the name of that drug, exactly how it damages the brain, and the precise conversation you need to have with your doctor, potentially this week. I'm Dr. Richard James, a senior health expert with over 3 decades of clinical experience. And what I'm about to share with you today is something I believe every family dealing with dementia needs to hear urgently. Here's the context. Antipsychotic medications are prescribed to hundreds of thousands of seniors with dementia every year. They're used to manage agitation, aggression, and behavioral symptoms that can make caregiving feel nearly impossible. For years, the medical community treated the stroke warning on these drugs as something that applied mainly to certain higher-risk patients. Doctors believed they could identify a safe group, patients without a history of heart disease or stroke, who could take the medication without serious vascular consequences. But a study published in the British Journal of Psychiatry involving over 165,000 dementia patients just shattered that assumption. The researchers compared 28,403 patients on this drug with over 136,000 matched controls. The conclusion was devastating. There is no safe group. The stroke risk was elevated across every single subgroup they examined. And we're not talking about a small trial or a preliminary finding. This was one of the largest studies of its kind ever conducted, spanning nearly 2 decades of NHS health records from 2004 to 2023. But here's what makes this even more troubling. Despite this evidence, this drug is still being prescribed every single day, and there is a very specific reason why. I'll explain that in a moment. First, you need to know the name of the drug. The drug is Risperidone. You might also know it by its brand name, Risperdal. It is one of the most widely prescribed antipsychotic medications for dementia patients worldwide. In the United States alone, it had over 2 million prescriptions in 2023. It's used to manage agitation, aggression, hallucinations, and behavioral symptoms that can make caregiving nearly impossible for families. Now, here's what most families don't realize. In the UK, Risperidone is the only antipsychotic of its kind that's actually licensed for use in dementia patients. In the United States, it carries an FDA black box warning, the most serious type of warning the agency can issue, stating that antipsychotic drugs increase the risk of death in elderly patients with dementia-related psychosis. That warning has been on the label since 2005, over 20 years. And yet Risperidone continues to be prescribed at enormous scale. That alone should raise questions. But stay with me, because the study data makes it far more urgent. Here's what this study found. The researchers, led by Dr. Byron Creese at Brunel University of London, analyzed anonymized primary care data from the UK's Clinical Practice Research Data Link, one of the most comprehensive health databases in the world. They identified every person diagnosed with dementia after age 65 between 2004 and 2023. Then they tracked stroke outcomes over 1 year, comparing 28,403 dementia patients who started Risperidone against over 136,000 carefully matched patients who did not take the drug. The matching was rigorous. They controlled for age, sex, dementia type, and existing health conditions, so the comparison was as clean as it gets in real-world research. The overall finding: Risperidone was associated with a 28% increased risk of stroke. The adjusted hazard ratio was 1.28. That means for every 100 strokes you would normally expect in this population, Risperidone was linked to 128. And this risk wasn't confined to one type of patient. It was consistent across all subgroups: patients with cardiovascular disease, patients without it, patients with a prior stroke, and patients who had never had one. Dr. Creese put it plainly. His team had hoped to identify specific characteristics that would make some patients more vulnerable. so doctors could avoid prescribing to those high-risk individuals. They couldn't. There was no safe group. Think about that for a second. If your mother has vascular dementia and she's been taking risperidone, she was never part of the original risk group that doctors were warned about. But this study says she should have been. The same goes for Lewy body dementia, frontotemporal dementia, mixed dementia. The stroke risk extends across the full spectrum of dementia diagnoses. Among patients with a prior stroke history, the numbers were staggering. The stroke rate reached 222 per 1,000 person-years for those on risperidone, compared with 177 for those not taking it. For patients with cardiovascular disease, the incidence rate was 94 per 1,000 person-years among risperidone users. Even among patients with no prior stroke or heart disease, the people everyone assumed were safe, the rate was 2.9 per 1,000 person-years on risperidone versus 2.2 without it. Those numbers might seem small individually, but multiply them across hundreds of thousands of patients, and they translate into thousands of preventable strokes every single year. The researchers also discovered something unexpected. Stroke risk appeared to be somewhat higher among patients who had only been on the drug for about 12 weeks, suggesting that the early stages of treatment may carry particular danger. Is your loved one on this drug right now? Hold that question, because what you need to understand next is why risperidone does this to the brain, and that explanation is the key to understanding how serious this really is. Here's what happens inside the body when a senior with dementia takes risperidone, and I need you to understand this because it explains everything. Risperidone is what's called an atypical antipsychotic. It works primarily by blocking two types of receptors in the brain, dopamine D2 receptors and serotonin 5-HT2A receptors. When these receptors are blocked, it reduces the signaling that drives agitation, aggression, and psychotic symptoms. That's the intended effect. That's what families see, the calming, the reduction in distressing behaviors. But here's what you can't see. Risperidone also blocks alpha-1 adrenergic receptors. Those are the receptors responsible for regulating blood pressure. When you block them, blood pressure can drop suddenly, especially when standing up or changing position. This is called orthostatic hypotension. In a healthy 40-year-old, the body compensates in seconds. But in a 78-year-old with dementia and fragile blood vessels, that sudden pressure drop can be enough to trigger a transient ischemic attack, a mini-stroke, or a full stroke. I want you to picture this. Your mother gets up from her chair in the nursing home. She stands, and for just a moment, her blood pressure plummets. The blood flow to her brain drops, and in that brief window, a clot that has been forming silently for weeks finds its opening. That's how fast it happens. Now layer on the second problem. Your blood vessels after 65 are not the same blood vessels you had at 40. The walls are thinner. The elasticity is reduced. The tiny capillaries in the brain, the ones responsible for delivering oxygen to the tissue that controls memory, speech, and movement, are more fragile than they've ever been. And when a powerful antipsychotic alters blood flow dynamics in a vascular system that is already compromised by age, the consequences can be devastating. Pay attention to this next part because it's critical. There's a third factor most doctors don't discuss with families. Risperidone is metabolized by an enzyme in the liver called CYP2D6. Some people are what pharmacologists call poor metabolizers. Their bodies break down the drug more slowly, so it accumulates to higher concentrations in the blood. After 60, liver function naturally declines. Kidney filtration slows. The drug stays in the system longer and hits harder. A dose that might be appropriate for a 50-year-old with healthy organs can effectively become an overdose in an 80-year-old with reduced clearance, and most prescriptions are never adjusted for this difference. A study published in CNS Neuroscience and Therapeutics found that risperidone increased endothelial injury and oxidative stress in hypertensive models. It amplified inflammation markers, specifically interleukin-6 and tumor necrosis factor alpha, in brain tissue. It also enhanced a protein called BAX that triggers cell death in blood vessel walls. In plain language, the drug was not just calming the brain, it was quietly inflaming and damaging the very blood vessels that keep the brain alive. So the drug is doing one thing you can see, reducing agitation. But it's doing something else you can't see, quietly increasing the pressure on blood vessels that are already vulnerable. And this study of 165,000 patients just confirmed that no group of patients is immune to that hidden damage. Now you understand what this drug does and how it damages the brain. But here's the part that genuinely frustrates me as a doctor. Because if the science is this clear, why is risperidone still being handed out in nursing homes and memory care facilities across this country? Here's the uncomfortable truth that the healthcare system doesn't want to talk about. Risperidone is still being prescribed at massive scale for one simple reason. There aren't many alternatives, and it makes caregiving easier. In many nursing homes and memory care facilities, behavioral management takes time, training, and staffing that simply isn't available. A pill is faster, a pill is cheaper, and a pill keeps the patient quiet. Non-pharmacological interventions, things like music therapy, environmental modifications, caregiver training, structured routines. These approaches work. The clinical evidence supports them, but they require dedicated staff, ongoing resources, and patience that most facilities simply don't have. When you're a nurse managing 30 residents with 3 aides and a patient is screaming at 2 in the morning, the system pushes you toward the prescription pad. That's not a failure of individual caregivers. That's a structural problem. And there's another layer: off-label prescribing. Risperidone was never approved by the FDA to treat dementia-related behavioral symptoms in the United States. It's prescribed off-label for this purpose, meaning doctors use it for a condition it was never formally tested and approved for. The FDA's own meta-analysis of 17 clinical trials found that the rate of death in antipsychotic-treated dementia patients was about 4.5%, compared with 2.6% in those taking a placebo, nearly double. That finding triggered the black box warning in 2005. And yet, more than 2 decades later, the prescriptions keep coming. And it goes deeper than that. A report released just weeks ago by the U.S. Department of Health and Human Services Office of Inspector General reviewed 40 focused nursing home inspections and found alarming results. Nursing homes were giving antipsychotic drugs to residents with dementia, specifically to manage behavior for the benefit of staff, not for the medical benefit of the patient. Even more disturbing, the OIG found that some facilities were inappropriately diagnosing residents with schizophrenia to mask their antipsychotic use and inflate their quality ratings. Here's how that works. Medicare tracks the percentage of nursing home residents receiving antipsychotics as a quality measure, but residents diagnosed with schizophrenia are excluded from that measure. So some facilities slapped false schizophrenia diagnoses on dementia patients to make their antipsychotic usage rates look lower than they actually were. Medical directors made these diagnoses to justify prescriptions. Pharmacists failed to recommend dose reductions. Required safeguards were routinely ignored. In the UK, NHS guidelines limit risperidone use to 6 weeks for severe symptoms. In reality, many patients remain on the medication far longer. Monitoring practices vary wildly across different regions, and there are currently no licensed alternative antipsychotics for treating severe agitation in dementia patients. I'm not saying your loved one's doctor is acting in bad faith. What I'm saying is that the system is structured in a way that makes it very easy to prescribe this drug, and very hard to question it. The old stroke warning was narrow enough that many prescribers felt comfortable. This new study removes that comfort entirely. So the drug is dangerous, the science is unmistakable, and the system keeps prescribing it anyway. I know exactly what you're thinking right now. What am I supposed to do about this? That's exactly what I'm going to tell you, and I want you to act on it as soon as possible. Now, I know some of you are thinking, but without this medication, my mother would be impossible to care for. The agitation, the wandering, the aggression, we tried everything. And I hear you. I genuinely do. Caregiving for someone with dementia is one of the hardest things a human being can do. The behaviors that risperidone is prescribed to manage are not minor inconveniences. They can be frightening. They can be physically dangerous. And the families living through it every day deserve empathy, not judgment. I am not here to dismiss that reality. This is not about yanking a prescription away. Stopping an antipsychotic suddenly can be dangerous in its own right. It can trigger withdrawal symptoms and a rebound in behavioral symptoms that can be worse than what you started with. No one should ever stop a medication without medical supervision. This is about something different. This is about walking into your next appointment armed with information that may not have been available when the original prescription was written. The science has changed, and your loved one's treatment plan should reflect the most current evidence, not the assumptions that were made years ago. If your doctor prescribed risperidone, it doesn't mean they made a mistake. It means they were working with the information they had at the time. But now there's new information, and the right response is to revisit the conversation, not to abandon it. If you're not sure whether your loved one is taking risperidone, here's what I want you to do right now. Check the medication bottles. Look for the word risperidone or the brand name Risperdal. If your loved one is in a care facility, you have every right to request a complete medication list in writing. If you're still unsure, call the pharmacy. They can tell you in 60 seconds. So here is exactly what I want you to do. This is what I would tell my own family, and I want you to follow it carefully. Step 1. Check the medications. Look at every bottle, every blister pack. If you see risperidone or Risperdal, that's the drug we've been talking about. If your loved one is in a nursing home or memory care facility, request the full written medication list. You have the legal right to see it. Step 2, and this is the most important step. Call the prescribing doctor and request a risk-benefit reassessment. You can say these exact words. A large study published in the British Journal of Psychiatry involving 165,000 patients found that risperidone increases stroke risk across all patient groups, including those without prior cardiovascular disease. I'd like to discuss whether this is still the best option for my loved one. You don't need to be a doctor to ask that question. You just need to be someone who cares enough to ask it. Step 3. Ask about alternatives. Request information about non-pharmacological interventions. Ask about behavioral strategies, environmental modifications, or whether a lower dose or a gradual tapering plan might be appropriate. Ask whether a referral to a geriatric psychiatrist is warranted. Step 4. Document everything. If your loved one is in a care facility, request that the reassessment discussion and any medication changes be noted in the patient's medical record. If the facility resists providing information or making changes, you have the right to escalate to the facility's ombudsman. This is not about confrontation. This is about informed advocacy. The science has shifted, and the people you love deserve a treatment plan that reflects the most current evidence. Your loved one trusted the system to protect them, and right now, you might be the only person in their life who knows what you just learned. If you found this information important, I need you to do something for me. Share this video with someone who has a parent, a spouse, or a grandparent in memory care. That one conversation, the one where they ask about risperidone, could be the most important thing they do this month. You could be the reason someone you care about has a conversation that protects someone they love. Subscribe to this channel because next week I'm covering something that every family with a loved one in a nursing home needs to know, and it connects directly to what we talked about today. The OIG report I mentioned goes much deeper than what I had time to cover here, and the findings will change how you think about the medications being given behind closed doors. I'm Dr. Richard James. Take care of the people who can't take care of themselves right now. They're counting on you. I'll see you in the next one.